Go ahead, Toby.
All right, so good, I guess, afternoon, everyone, and welcome back to Grand Rounds. Happy New Year. And so our first speaker is Dr. Ahmed Luqman, and he is Assistant Professor of Clinical Medicine in the Department of Hospital Medicine. And so he completed medical school at Baghdad College of Medicine, after which he went on to do a social service primary care year, and then internal medicine residency at Al-Noor Teaching Medical Center in Iraq. Afterwards, he then completed internal medicine residency at Jamaica Hospital Medical Center in Queens, and then afterwards worked as a teaching hospitalist for a year. Since 2021, he's been an assistant professor of clinical medicine here at the University of Miami Miller School of Medicine, and currently serves as the sub-I clerkship director for the sub-internship for internal medicine, and has been integral in governing the phase 3 movement of medical students in our curriculum. And we're so grateful to have him here with us today to talk to us about a curious case of acute hepatocellular injury, a clinical vignette. And so please give a warm welcome to Dr. Ahmed Luqman.
Thank you so much, Dr. Ubu, for this kind introduction. Hello, everyone. I will basically get right to it. I'm here basically to discuss this interesting case that we had on the wards of an acute hepatocellular injury. So I have no disclosures for this presentation, and our objectives will be basically to discuss an unusual presentation of a febrile hepatocellular injury, and also to recognize a coincident or a confounding symptom that can mislead or manage. I'll start with the case presentation. This basically was a 23-year-old female who's otherwise healthy, no significant past medical history. Presented to the hospital complaining of fever, intermittent fever, and headache, severe unilateral headaches that's associated with blurred vision, neck pain, nausea, and vomiting for about 10 days prior to presentation. And she mentioned that it has been getting worse. She reported no recent history of travel, sick contacts, or trauma. She denied excessive alcohol intake. She denied illicit drug use, and she reported being sexually active with consistent use of barrier protection. On physical exam, the patient was noted to be febrile and with a temperature of 100.7 in the ER, and she was tachycardic. She was ill-appearing. Her vital signs otherwise were stable. She was ill-appearing. She was her exam otherwise was fairly normal. She was neurologically intact, no meningeal signs. She was alert and oriented ×3. She did not have any significant skin rash. So upon initial workup, the CBC showed CBC was fairly normal. Her counts were normal, but there was some lymphocytic predominance with 62% lymphocyte, and her serum chemistry was significant for a severe elevation in LFTs. Her AST was 260, and her ALT was 290. Her alk phos and her T-billy were normal. And like otherwise, her initial workup was unrevealing. Her chest X-ray was normal. Her UA did not show any prior bacteriuria. Her CT head was negative for acute pathology. Flu and COVID testing were negative as well. Given that she has this severe elevation in liver enzymes and presents with fever, the first thing we did is we proceeded to get viral hepatitis panel. She had a positive IgG for hepatitis A, but otherwise all the serological workup for viral hepatitis was negative. Her peripheral blood smear was negative with no morphologic abnormalities. Her HIV antibody was non-reactive. Monospot test was negative. Synthetic liver function was normal, and a right upper quadrant ultrasound showed a normal liver. We asked her about Tylenol use at home because she's been having the headache and the fever, but she denied excessive Tylenol use. She said that she used it every once in a while, but nothing more than 1,500 milligrams a day. And her acetaminophen level was below 15 milligrams per liter in the ER. I'd like to see if anyone has any thoughts so far about like how to proceed. So going forward, given that the patient's presentation is fever, acute onset headache, severe headache, so we were thinking, acute meningitis, encephalitis. So we proceeded to do a lumbar puncture. Initial CSF studies were not really concerning for anything like that. Her cell counts are 0 RBC, 0 white blood cells, and her CSF chemistry was within normal limits. So continuing with the hospital course, she was placed on empiric broad spectrum antibiotics, and infectious disease service was consulted at that point. They recommended to get serology for toxoplasma, CMV, and EBV, and also recommended to get PCR for CMV, EBV, and HIV viral load as well. So all these tests were ordered. At that point, patients continued to have these intermittent high fevers, which was manageable with antipyretic medications, and she's continued to have these episodes of severe headache that was unilateral most of the time, and all blood cultures until hospital, that was at hospital day 2, all blood cultures were negative, the ones that were collected initially and the ones that were collected afterwards. So liver enzymes continued to rise, and they peaked at hospital on hospital day 2. They peaked at 583 for ALT and 516 for AST, with a normal total bilirubin and a normal alk phos at that point. So next day, we had results back from the EBV IgM and the CMV IgM were both positive in high titers. So at that point, we figured this is an acute EBV CMV co-infection, and we stopped antibiotics, and basically, usually treatment for these acute infections is usually supportive, so we continued supportive therapy. Patients started improving, fevers started to become less frequent, and it eventually subsided. Headaches got better as well, and liver enzymes started to trend down at that point. So basically, during the hospital course, we asked the patient about like prior history of headaches, and she did confirm that she had similar episodes in the past, similar to this headache that she had this admission. So our conclusion was basically that the headache was, we attributed it to migraine, which was likely triggered by the physiological stress of the systemic infection and fever. Eventually fever subsided completely, and patient improved symptomatically and was discharged home stable, and she was instructed to follow up with her PCP. And we also recommended her to see a neurologist for migraine management. For the record, she has never been officially diagnosed with migraine, but that was our clinical suspicion, so we referred her to neurology. And upon 1 month follow-up, patients was seen and found to have a completely normal liver enzyme and completely normal serum chemistry, basically. Discussing this case, first of all, we have to start saying that EBV and CMV can cause so EBV is a herpes virus, it's class gamma, and it can commonly causes infectious mononucleosis in immunocompetent adults. And CMV is also a herpes virus, it's class beta, and it can cause a mononucleosis-like illness in adults as well. With mononucleosis, there is commonly liver involvement, and there is some LFT elevation that has been noted, but usually it has not been noted to be more than 5 times the upper limit of normal, which is usually, if the liver enzymes are elevated 5 to 10, or sometimes even more than 10, the upper limit of normal, we consider hepatotropic viral hepatitis, which is hepatitis A, B, C, E, and D, and then or toxic or ischemic injury. But in our case, we were suspecting that this severe elevation was probably because of the co-infection of 2 viruses at the same time, if that makes sense. And basically, because usually asymptomatic liver enzyme elevation associated with mononucleosis is a lot less than that. So our case was different from all the reported cases. Like specifically co-infection with EBV and CMV is something that has not been commonly described in the literature. So upon our literature review, we saw a very few cases reported. And most of these cases were associated with a clear mononucleosis picture, along with acute hepatocellular injury or hepatitis. So one of the cases was in a young female who basically came to present diagnosed with acute co-infection of EBV and CMV, causing acute hepatitis, but it was also associated with a mononucleosis picture. She had fever, she had pharyngitis, and cervical lymphadenopathy, and similar level of liver enzyme elevation. We also found another case that, but that was in a pediatric patient. Basically, it's also co-infection with EBV and CMV causing severe acute hepatitis. But again, our case is different because there was no clear mononucleosis. Patient did not have pharyngitis, did not have cervical lymphadenopathy, no hepatosplenomegaly or atypical lymphocytes on blood smear. The other cases that we found that were reported were a case of acute co-infection of acute hepatitis with co-infection with EBV, CMV, along with hepatitis E, and another case, these 2 viruses with hepatitis C. And both of these cases were severe acute hepatitis, similar presentation. And then we also found another a case of acute fulminant hepatitis requiring emergency liver transplant caused by cytomegalovirus, and another case that was fatal fulminant hepatitis caused by EBV, which was, this case was fatal, it was reported in France. So our key take-home points from this case is basically that EBV and CMV can cause significant illness in a young, healthy, immunocompetent person, and should be considered in a presentation like that. And EBV and CMV can also cause hepatocellular injury or acute hepatitis with or without mononucleosis. The other point that I wanted to emphasize on is to use your resources, and then utilizing these resources early in the course of the management could basically result in better outcomes, could result in shorter length of stay, and basically lower cost. Because, like in this case, we consulted infectious disease early in the course, and they guided us to get the CMV and EBV serology. And that's what we did. And we were on the verge of going into doing autoimmune workup for this patient, which could have, increased her length of stay, which could have caused her a lot more discomfort and probably increased the cost of the hospitalization as well. Does anybody have any questions or comments at this point?
Yeah, well, I think your case very nicely illustrates that every cause of acute hepatic dysfunction, which appears to be infectious, is not necessarily the A to E viruses. And both CMV and EBV are more typically a concern in immune-compromised patients, but they're actually pretty common causes of an acute viral hepatitis in the community as a whole.
Thank you very much.
Thank you, Dr. Luqman. We have a few minutes. Maybe I can, one of the things that you did, what we see commonly is the starting of what you said is empiric antibiotics, broad spectrum antibiotics. At what point did you realize that those were no longer needed and stop them? And what were you treating? What infection were you treating with the broad spectrum antibiotics when you started them?
So basically we were not really sure what infection were we treating, but because the patient was febrile and presenting with, initially we were thinking, like the first day we were thinking acute meningitis, but after the LP was done and the results were negative for acute meningitis, we continued antibiotics for one more day until we had the results of the EBV and the CMV back. And that's part of what I said about like utilizing the resources, because we probably had continued antibiotics further if we had not gotten those results early. So that's basically, we cut the cost, we cut any extra discomfort and extra risk of side effects from antibiotics for the patient.
I see. So the initial indication for the antibiotics was you were concerned she had meningitis, but you started them before you got the LP. She was hemodynamically stable. She was just febrile and had a headache.
That is correct.
Yeah. Okay. Dr. Dobbin has a question. What is the incidence of cross-reactivity of the two tests?
Okay, I did have a slide prepared for that. So I didn't want to take up a lot more time, but so this basically, there is a concern, it has been described in literature, of cross-reactivity in serology for these two tests. And it was actually brought up to me when the patient was still hospitalized. And for that, we ordered PCR testing for both. But yeah, there is some incidence, and there was a study that was published in June 2022 that looked into that matter, and there was only a minority of cases. It was tended to be like false positive, but this concern is valid, and it's usually basically looked at based on the clinical context. But we did consider that. And I'm not 100% sure of what the exact incidence is, but in that study that was published, like the most recent study that was published looking into that, that said it's only a minority of cases that had a false positive serology with a negative PCR or viral load.
Thank you, Dr. Luqman, for that presentation and for that answer. Why don't we continue with our next speaker, Dr. Ubu?
Thank you so much.
Thank you.
Thank you. All right. And so our second speaker of this afternoon is Dr. Carl Orringer, our professor of clinical medicine at University of Miami. And so a little bit about Dr. Orringer. Dr. Orringer started at Case Western, but then fled the cold winters for year-round summer, completing his bachelor's at UM and obtaining his MD at Miller School of Medicine, where he was AOA, and then finally completing internal medicine residency here with us. He then went on to complete cardiovascular disease fellowship at Brigham Hospital and worked in New Orleans as a private cardiologist prior to joining the faculty of University of Michigan Medical Center. He returned to Case Western Reserve University, this time at the School of Medicine, where he served on the faculty for 16 years prior to becoming the chair of preventative cardiovascular medicine for 5 years. After 20 years of being back in the cold and winning numerous awards, such as finalist in Healthcare Heroes Awards twice and 4-year recognition by Cleveland Magazine as Best Doctor, Dr. Orringer returned to University of Miami, where he has served since. He has numerous first author publications focusing on dyslipidemia primarily, and most recently is a co-author in the Department of Defense Guidelines for Management of Dyslipidemia and the American College of Cardiology Expert Consensus on ASCVD risk reduction in patients with persistent hypertriglyceridemia. He has served as the editor, faculty chair, and editor-in-chief of the National Lipid Association, president of the National Lipid Association, and has received multiple awards from both the American College of Cardiology and the National Lipid Association. He's been recognized for his clinical teaching and mentorship, both here and at other institutions, and we're so glad to have him here with us today. Please give a warm welcome to Dr. Carl Orringer, who will be talking to us today about a cardiovascular update, lipid management in 2023.
Well, thank you so much for that kind introduction. What I'm going to do is to focus today on some newer aspects of lipid management, and I think it's important because this is such a rapidly advancing field that I wanted to make sure that everyone has a pretty good idea of what's going on. It's a challenge to do it in a brief presentation, but the shorter the presentation, the bigger the challenge. So let's go ahead. First of all, I have no disclosures that relate to this presentation. The objectives of today's discussion is to give you newer information on statin intolerance. I'm going to also give you new information on statins, particularly statin legacy effect, PCSK9 inhibitors, and inclisiran. I'm going to also provide key information on the management of high triglycerides, and then briefly summarize the latest ACC recommendations on the clinical use of non-statins. Now, we really now have conclusive data that the lower the LDL cholesterol, and for the longer time that LDL cholesterol is successfully lowered, better will be ASCVD outcomes. As an individual's genetics underpin all attempts at LDL cholesterol lowering, but lifestyle habits moderate these levels to varying degrees. Fortunately, statins and other lipid-lowering therapy have been shown to play an important role in reducing LDL-related risk in both primary and secondary prevention, and the beneficial effects of lipid-lowering therapy are diminished by an unhealthy lifestyle and less than optimal adherence to statins and other lipid-lowering therapy due to either true or patient-perceived medication-attributed symptoms. So there's clear RCT evidence of statin benefit both in primary and secondary prevention, both men and women, in those at low cardiovascular risk, in those with diabetes, individuals with severe hypercholesterolemia, and in older individuals up to the age of 75. There's an interesting effect that's recently been observed called the statin legacy effect. This refers to ongoing risk reduction benefit for subjects of a clinical trial after the trial has been completed. This effect was well demonstrated in a well-known statin primary prevention trial, the HOPE-3 randomized controlled trial, in which over 12,000 subjects with a mean age of 65 who are at intermediate risk were given either rosuvastatin or placebo and followed up for a median period of 5.6 years. And rosuvastatin 10 milligrams was associated with a 24% relative risk reduction versus placebo in the subsequent incidence of cardiovascular death, non-fatal MI, or non-fatal stroke. But recently, a follow-up study, which looked at 9,326 individuals who were in the original study, followed up for a median of 3.1 years after completion of the study, when they were returned to their usual care with their primary care physicians, showed an additional 20% relative risk reduction in those originally randomized to rosuvastatin therapy. So this can be used when you're telling your patients why they should take their statins. You can remind them that the benefit tends to increase over time, such that the longer they take it, the greater their benefit. there's been a lot of discussion about what are potential toxic effects of statins. And I think we can pretty well eliminate neurocognitive disorders, hemorrhagic stroke, or renal toxicity from statins. It just does not seem to exist. The only real side effects that you could see are that some people report statin-associated muscle symptoms. There are, in some people, temporary transaminase elevations, although a lot of that occurs in the setting of fatty liver disease. And then there is a mild increase in the incidence of newly diagnosed diabetes, but this tends to occur only in those with diabetes risk factors. Now, one of the questions we need to ask is, are statin-attributed muscle symptoms real, or are they fake or perceived by patients when they don't really exist? So this next slide refers to a study called GALS-3, and that stands for Goal Achievement After Utilizing an Anti-PCSK9 Antibody in Statin-Intolerant Subjects. In this study, 511 patients with uncontrolled LDL cholesterol and a history of intolerance to 2 or more statins were entered into 2 phases of a study. The first phase was a 24-week crossover study in which they received either 20 milligrams of atorvastatin or placebo to identify those with symptoms that only occurred on atorvastatin but not on placebo, and those who had symptoms only on placebo but not on atorvastatin. And then the second phase of the trial was when patients were randomized to either receiving ezetimibe or placebo for 24 weeks to look at comparative LDL cholesterol lowering efficacy. The main thing I want you to focus on, though, is phase A, in which 26.5% of people had muscle symptoms on placebo, but not on atorvastatin, and 42% had muscle symptoms on atorvastatin, but not on placebo. So it really helps you understand that the water is pretty muddied when it comes to the question of how much of these muscle-related symptoms are real and how much of them are patient anticipated. So what we really need to look at is what do large studies tell us about whether these symptoms are real or whether they're actually patient perceived. Well, there was a recent meta-analysis done by the Cholesterol Treatment Trialist Collaboration, which addressed this question in 19 placebo-controlled trials of either statin versus placebo or less intense versus more intense statin therapy, and specifically examined a variety of muscle symptoms reported by subjects in these studies over a median follow-up of 4.3 years. And as you can see by looking at the forest plot, there was essentially no difference in reported symptoms in either statin versus placebo or less intense versus more intense statin regimens. So these investigators concluded, and you can see that next to the megaphone, that really these statin-associated muscle symptoms are largely misattribution. They're going to occur whether or not the patients are on a statin or not. So let's look at the other end of the spectrum. There's a different story now that's portrayed in this huge meta-analysis published in the European Heart Journal of 176 studies looking at over 4 million patients. And what they found was that the overall prevalence of statin-associated muscle symptoms was about 9%. And they felt that, based upon their data, they suggested that Asian race, Black race, obesity, hypothyroidism, diabetes, various antiarrhythmic drugs, alcohol consumption, and exercise, along with other demographic features like what is their age, are they male or female, do they have chronic liver disease, chronic renal disease, are they on calcium channel blockers, and are they on a higher dose of statin? All of those seem to be associated with a higher likelihood of statin-associated muscle symptoms. On the other hand, they found that factors like smoking, hypertension, duration of statin therapy, white race, Caucasian race, Hispanic race, and warfarin did not seem to be related to statin-associated muscle symptoms. So their perception on this issue was that statin intolerance is for real. So, and really, those of us who take care of patients don't have any questions. Statin intolerance in some patients is for real. And when patients have it, they complain of bilateral, proximal, and symmetrical muscular symptoms. They usually occur in large muscle groups. They begin within weeks of initiation or increase in the intensity of the statin, resolve within a few weeks after stopping it, and recur after statin rechallenge, particularly with a starting dose. So the question we have to ask is, when people complain of these symptoms, how much of this is for real and how much of this actually could be so-called nocebo effect? And what is the nocebo effect? The nocebo effect is patient awareness and concern that symptoms will develop on a medicine when they begin the medicine. So it's the belief that precedes the initiation of therapy that they're going to have certain side effects. And this so-called nocebo effect was actually examined in two studies done in England, one of 60 patients and one of 200 patients who were given either atorvastatin or placebo and were followed over a period of time for muscle symptoms. And both of these studies, although they were relatively small, showed that symptoms tended to occur equally frequently, whether they were taking statin or placebo. So what you have to do when you see a patient in clinic is you have to kind of make a decision about whether you think those symptoms are related to statins. If they are, you have to take a rational approach to trying to ferret this thing out to decide what are you going to do for the patient. When patients already have established ASCVD, you got to do everything you possibly can to keep that patient on the statin. But when patients are being treated for primary prevention, where you're not 100% sure how much the patient is going to be benefited, one thing that you might do, one test that might be of help to you is coronary calcium scoring. And we published this article in the Journal of Clinical Hepatology in 2021 in collaboration with Dr. Mike Blau from Hopkins and Neil Stone from Northwestern. And what we did was we came up with an algorithm which seemed to be a reasonable approach that could be used for patients who present with muscle symptoms. In fact, muscle symptoms while on a statin may either be typical or atypical. If they're typical, frequently then we will try to find out by how we can help this patient by temporarily discontinuing the statin and then looking for the presence of intervening medical conditions that might affect the muscle, looking for drug-drug interactions, and checking things like 25-hydroxyvitamin D, TSH, or CK. Every once in a while, you run into a patient with a vitamin D level of 6, and you know that by replenishing their vitamin D, they may be less prone to muscle symptoms. On the other hand, if the symptoms are atypical, then this could be related to either an exacerbation of the underlying or pre-existing muscle disorders that the patient has, or maybe nocebo effect. In either case, the decision-making process in reinitiating the statin or non-statin therapy may be made either on clinical grounds, which is a discussion that you have with the patient, a clinician-patient discussion, or may be aided by the use of coronary calcium scoring. Because in these patients, again, these are people who do not have established ASCVD, if they have calcium scores of 0 and they don't have diabetes, are not smokers, or don't have a family history of premature ASCVD, lifestyle therapy without statin therapy may be a reasonable approach for such patients. If they have calcium scores of greater than 100 or the 75th percentile for their age, sex, and ethnicity, statin therapy, oftentimes, in certain cases, even with additional non-statin agents, may be considered. If they have a calcium score of 1 to 99, and they're under 55, and they have less than the 75th percentile for their age, sex, and ethnicity, you got a clinician-patient discussion there to decide if you're going to initiate a statin. But if they're over 55 with a calcium score of 1 to 99, probably a good idea to get those people going on a statin. So this is a way that you can make that decision, and that patient who comes to you with having had side effects of multiple statins, and you're saying, should I restart this patient or should I not restart this patient on a statin? Calcium scoring can often be helpful in making that decision. So to summarize statin-attributed muscle symptoms, first of all, taking a good history is key in determining whether muscle symptoms are likely due to the statin. If they have pain in their elbow or pain in their heel, it's not from the statin. You want to make sure that they have a typical pattern that is characteristic of statins. When there's patient hesitancy to take a statin, explore the reasons, respect the patient's perspective, and in selected primary prevention patients, consider coronary calcium scoring as an aid to shared decision-making. And then remember that statin avoidance or reinitiation for primary prevention is aided by the knowledge of how much coronary calcium is present. Well, you know, we're now entering in a phase in which we're talking a lot about PCSK9 inhibitors, but now we have two categories of PCSK9 inhibitors that are available to us. One is the PCSK9 monoclonal antibodies, which are evolocumab and alirocumab. And we now have a new category of PCSK9 inhibitors called the RNA silencers, which for which we only have one available at this time, called inclisiran. So the PCSK9 inhibitor studies the initial studies were actually short-term, showing relatively short-term benefit. And the original Fourier trial, for example, was done in a very high-risk group of patients with stable ASCVD, but with a median follow-up of only 2.2 years. More recently, the Fourier Olay study, which really looks at long-term outcomes of people treated with Fourier, treated with PCSK9 inhibitors, showed excellent safety to a median now of up to 5 years. So we now know these drugs are safe, at least in the 5-year window of follow-up. This particular study also showed that there was a reduction in the incidence of MACE over that time period, but that was not a primary endpoint of this particular study. But everything is pointing toward good long-term safety and good long-term outcomes in patients treated with PCSK9 inhibitors on top of maximally tolerated oral therapy. Now, another type of PCSK9 inhibitor is inclisiran. And inclisiran is an RNA silencer, and I'll discuss this mechanism in just a second, but it's given by injection in a physician's office or in an infusion center. It's dosed initially at 3 months and then every 6 months thereafter. And patients who take this get a sustained roughly 50% reduction in LDL cholesterol. The medicine is generally well tolerated, although mild injection site reactions were reported in under 10% of patients taking the drugs in clinical trials. And there are ASCVD outcome trials in progress, but this drug was approved by our Pharmacy and Therapeutics Committee in September 2022, and we are now waiting for final initiation of this because we've got to get it set up in EPIC for our clinicians to use. Now, the next issue is, what is it about this drug that enables it to be given relatively infrequently? Well, this slide focuses on the mechanism of action of inclisiran, and it's a drug that binds to the RNA precursor of PCSK9, which enhances its degradation. The inclisiran molecule has 2 complementary strands of RNA, one of which plays the role as a guide strand, and the other is called the passenger strand. Now, this GalNAc tail that is on the inclisiran molecule focuses the molecule to the liver. And once inclisiran is incorporated into the hepatocyte, it is then, the guide strand then binds to this multi-protein complex called the RNA-induced silencing complex. And the guide strand hybridizes with the complementary RNA for PCSK9 and promotes its degradation in lysosomes inside the liver. With less production of PCSK9, there's more recycling of these LDL receptors to the surface of the hepatocyte, thus being able to take more LDL out of the circulation. And the prolonged duration of action of inclisiran relates to its prolonged activation of this RNA-induced silencing complex. So it works, it continues to work, it continues to work, thus enabling us to give it initially at 3 months and then only twice a year thereafter. And it takes the adherence issue out of the picture because you know your patient is going to have the sustained reduction in LDL cholesterol. So that's an exciting new intervention that is actually going to be clinically available to us at UMH very shortly. Let's next move on to the issue of triglyceride-rich lipoproteins. And I had the privilege of working on this particular document through the American College of Cardiology. We published it in 2021. Now, the mechanism of action by which triglyceride-rich lipoprotein particles promote atherosclerosis is thought to relate to enhanced delivery of cholesterol esters to tissue macrophages, which take up esterified cholesterol in an unregulated fashion, as compared to what happens. Let's see, I think we lost that for a second. Give me a second to get out of this. I don't know why that popped up, but let's see if we can get that going. There we go. Sorry. So basically, what happens is that These triglyceride-rich lipoproteins deliver cholesterol ester to the tissue macrophages in an unregulated fashion, as compared to that which occurs when LDL particles deliver cholesterol esters to macrophages, because they have to deliver their cholesterol through receptors. So when these triglyceride-rich lipoproteins deliver their cholesterol, it loads these macrophages with cholesterol ester, resulting in the formation of foam cells, which are characteristic of atherosclerotic lesions. So another mechanism whereby these triglyceride-rich lipoproteins promote atherosclerosis is through their effect to increase inflammation and to increase thrombosis and adhesion of mononuclear cells to the endothelial surface, all of which are pro-atherosclerotic. So now, in this particular document, we moved into the key issue is what do you do for patients who have high triglycerides, because we know that they're at increased risk. And a key point for you to remember is that when you see a patient with hypertriglyceridemia, there's a critical role of both diet and exercise to reduce triglycerides, regardless of whether patients are or are not taking triglyceride-lowering drugs. The focus should be on the reduction of simple carbohydrates, including alcohol and total fat, with progressively more restriction in those as people's triglycerides are higher. In addition, patients should be advised at least 150 minutes per week of moderate intensity exercise, preferably in 5 sessions, or 75 minutes or more per week of higher intensity exercise, at least in 3 sessions. And in addition to that, preferably a loss of about 5 to 10% of body weight. This can really give you a very marked reduction in triglyceride levels and a reduction in cardiovascular risk. But there are some simple things you can do in the clinic when you see such patients. You can ask them these screening questions, like how often do you drink sugary drinks? How often do you drink soft drinks? Can you drink water instead? Do you eat pastries, desserts, candies? Do you drink alcohol? If so, how much? Do you consume foods that are high in saturated fat? How much weight have you gained in the past year? Do you do physical activity? And if so, how much? These are practical, easy to use questions. And I encourage you to take a look at this article because it gives many practical pointers about what one can do in the clinic to positively affect the outcomes of these patients with high triglycerides. So instead of making them feel terrible about all the things they can't do, let's talk about some things that they can do. Like instead of drinking sugar-sweetened beverages, try no-calorie sparkling water. Instead of eating pastry, dessert, or candy, try some fruit every once in a while and maybe some dark chocolate. If you drink alcohol, don't drink too much. If you want to lose weight, don't follow fad diets, but follow diets that have been shown to have cardiovascular benefit, like the Mediterranean diet. If you're not used to exercising, start slowly and advance, particularly if you have a partner to exercise with you to help you with your motivation. And even if you don't have time to do that, try parking farther away, using stairs instead of an elevator, and standing more of the day rather than sitting during most of your daily hours. So in considering triglyceride disorders, consider the role of the patient's diet, exercise habits, whether they're taking drugs that may increase triglyceride levels, and various diseases, in particular type 2 diabetes and prediabetes, hypothyroidism, and chronic kidney disease. But when you see high triglycerides, think lifestyle first. Only consider drug therapy in higher risk states, especially when triglycerides are greater than or equal to 500. Consider moderate or high intensity statins for those with triglycerides of 500 to 999, except in those who've had pancreatitis, where you may need to add specific triglyceride lowering drugs like fibrates or prescription omega-3 fatty acids. And those drugs are especially useful in those with triglycerides greater than 1,000. But once their triglycerides go below 1,000, use a statin, because a statin not only helps to lower triglycerides, but it also protects against cardiovascular events. And finally, I want to make just one or two comments on this most recent paper, which we just released. I participated in this. It's the 2022 ACC Expert Consensus Decision Pathway on the role of non-statin therapies for LDL cholesterol lowering. And this paper really helps you to know when you should be thinking about the use of non-statins after you've done the most that you think you can do from a statin. And this paper looks at a whole host of non-statin agents. The most frequently used is ezetimibe, which is a cholesterol absorption inhibitor that generally produces about an 18% reduction in LDL cholesterol, but in some patients may give you considerably more. And you may be surprised sometimes that patients who get even a modest LDL lowering response from a statin sometimes get a tremendous additional LDL lowering response when you add ezetimibe. Bile acid sequestrants are rarely used due to high pill burden and gastrointestinal side effects. Bempedoic acid is a liver-specific prodrug that inhibits the enzyme ATP citrate lyase, which is a step upstream to HMG-CoA reductase in the cholesterol biosynthetic pathway. It requires activation by a specific enzyme that is present only in the liver, but not in skeletal muscle. And the lack of skeletal muscle activity of this enzyme is postulated to decrease the risk of muscle-related symptoms in patients treated with bempedoic acid. Unfortunately, it is still a brand name drug and therefore is more expensive and not widely available for patients, but does lower LDL cholesterol 17 to 28% in clinical trials. And also I want you to just keep in mind that this drug does raise uric acid levels, so it should be used with caution in those with a history of hyperuricemia or gout, and has been associated with a slightly increased risk of tendinitis and tendon ruptures. We've also already discussed monoclonal antibodies for PCSK9 as well as inclisiran, and lomidopide and evanicumab are drugs used in patients with homozygous FH, but that's beyond the scope of today's discussion. But I want to bring up just one or two final points on this particular document that we just published. One is that the document has set goals for primary prevention, LDL cholesterol less than 100 and non-HDL cholesterol, which is total minus HDL cholesterol of less than 130. Goals for secondary prevention for high-risk patients are less than 70 and non-HDL cholesterol less than 100, but for very high-risk patients, and by the way, that means people who have had 2 or more major ASCVD events that are listed on this side of the slide, or 1 major event and 2 or more of these high-risk conditions. So those people are considered to be very high risk, and those people generally have about a 40% or more 10-year risk of ASCVD. For those people now, we're suggesting an LDL cholesterol goal of less than 55 and a non-HDL cholesterol goal of less than 85. And this is in concert with the European guidelines as well. And another aspect of this paper that is unique and was not discussed in the previous, actually in the cholesterol guidelines, is that the results of coronary calcium scoring may be used to aid in decision-making about the goals for LDL cholesterol and non-HDL cholesterol in primary prevention patients. So that if you have a patient who's at borderline or intermediate risk, according to their assessment using the pooled cohort equations, if they have a calcium score of 0, it may be reasonable in those people to simply defer the use of statins and reimage in 3 to 5 years and just go ahead with lifestyle therapy. If they have a calcium score of 1 to 99 and in less than the 75th percentile, a moderate intensity statin should be used. And if they don't achieve that with a moderate intensity statin, you can intensify therapy to a high intensity statin if they don't achieve a 30 to 49% LDL cholesterol reduction. Those who have CAC scores of 100 or greater than the 75th percentile, you can initiate therapy with a moderate or high intensity statin, and your percent LDL reduction that you're looking for depends upon whether you use moderate or high intensity. But definitely want an LDL cholesterol goal less than 70 and non-HDL cholesterol goal less than 100. And if you need to, you can add ezetimibe to your statin in such patients. Finally, and this is a very interesting group, those who have calcium scores of 1,000 or greater are at an extremely high risk. Their risk is actually in the range of 40% or higher in 10 years. In those people, you want high intensity statins if at all possible, ezetimibe if necessary, to get to an LDL cholesterol goal of less than 70 and non-HDL cholesterol goal of less than 100. And in selected cases, you may actually use a PCSK9 inhibitor in such patients because their risk has been documented to be quite high. So in summary, clinicians should use a systematic evidence-based approach to the diagnosis and treatment of patients with statin-attributed side effects. Secondly, calcium scoring may be useful in patients with statin-attributed symptoms to decide on statin treatment benefits. Both statins and PCSK9 monoclonal antibodies have been shown to reduce ASCVD risk and have a legacy benefit to provide ongoing risk reduction, even when you take patients out of clinical trials. Inclisiran effectively lowers LDL cholesterol, does it in a sustained fashion with long-term therapy of only twice a year, and is now being evaluated as an adjunctive treatment for ASCVD risk reduction. Lifestyle approaches should be the first thing you think about in people with high triglycerides, and you consider drug therapy only in selected patients. And finally, to really focus in on the newest approaches to non-statin therapy, I encourage you to read the 2022 ACC Experts Consensus Decision Pathway paper on non-statin therapy. So those are my comments, and I would be happy to address any questions.
Thank you, Dr. Orringer, for an absolutely beautiful grand rounds, a nice review of the topic. You do mention the role of calcium scoring as a useful adjunct to help guide your therapy. Is there any evidence that use of these therapies can reverse the score after a period of time, or is it only useful to follow at the beginning?
Yeah, so one of the things to remember is that coronary calcium is an indicator that cholesterol has moved into the arterial wall. And we could not know this in the absence of seeing calcium there. So one of the things to remember is that the calcium is not the enemy, it's the cholesterol underneath the calcium. And so in fact, these treatments that we give deplete the cholesterol plaques of their cholesterol content, but don't change the calcium that's already there. So calcium scores do not go down over time. What we really want to know is there any evidence to suggest very rapid progression? And so in people who have scores of 0, for example, we like to recheck their coronary calcium in a period of 3 to 5 years to see if it remains 0. If they have calcium scores of 100 or greater, you don't need to repeat it because you already know they have significant coronary atherosclerosis. So it basically, in most cases, it's not necessary to repeat the calcium score, except in selected clinical circumstances. But what the treatments do is they deplete cholesterol from underneath these calcium deposits, but one's not going to see regression of calcification if a person's calcium score is repeated.
Thank you for that.
Sure.
Hi, I have a question. This is Venetia. So in clinics, right, like when we initiate statins and the LDL start coming down, is there like a cutoff point where we say, okay, the cholesterol is low enough now, we can stop statins or hold off on statins? Like, is there a value that, is there something like a cholesterol that is too low, an LDL that is too low, and we should hold off on statins, or we just continue treatment once it's been elevated?
So the benefit of statins really relates to the degree of LDL lowering and the persistence of that LDL lowering. So if one stops a statin, you're going to stop getting the benefit that the statin gave you. You may have a slight legacy benefit, but in fact, there is no level of LDL cholesterol that's too low. In fact, there have been studies that have employed statins or statins plus ezetimibe or statins plus ezetimibe plus PCSK9 inhibitors. And they did subgroup analyses actually of large numbers of patients who achieved LDL cholesterols between 0 and 10. They had the best outcomes. So in fact, there is no floor for LDL lowering. When I previously worked in Cleveland and had a large lipid clinic there, we did LDL apheresis, in which we, in selected patients, when we would literally filter the blood because they were not responsive to other therapies to lower their LDL cholesterol. And very frequently, patients would walk out of the apheresis suite with an LDL cholesterol of 0, and they were fine, and they had no adverse effects, and they did very well. So the answer is there is no floor for LDL lowering, and the lower you get it for the longer that you lower it, the better off the patient's outcomes are going to be.
Okay, thank you.
Welcome.
I have a quick question, Dr. Orringer. For people with familial hyperlipidemia, do you classify them as very high risk or as high risk in terms of the recommended LDL and non-HDL level?
Okay, so in this interesting category of people with familial hypercholesterolemia, we have to decide who are the highest risk patients. And those are the patients who have not only, first of all, they're the highest risk patients when they have very high LDL cholesterols. And there's a spectrum of LDL cholesterol levels that you might see. Some might present with LDL cholesterols that are only 190 or even less than 190. Many of them have levels that aren't 190. Then there are some you see with LDL cholesterols of 350, and they're extraordinarily high. So the answer is the higher the LDL cholesterol, the higher the risk. But then there are other factors that you have to consider along with LDL cholesterol level. And that is, number one, what is their burden of concomitant risk factors? So are they hypertensive? Do they have diabetes? Do they have strong family histories of early heart disease? Do they have poorly controlled risk factors? Another important risk factor in patients with elevated LDL cholesterol or familial hypercholesterolemia is lipoprotein A. Lipoprotein A is a particular subpopulation of LDL particles that carries a prothrombotic tail on it called ApoA, which not only increases the risk of atherosclerosis, but also increases the inflammation of the arterial wall, and thus more aggressively promotes atherosclerotic vascular events along with valvular aortic stenosis. So those who have poorly controlled risk factors and concomitant elevation in lipoprotein A are at the highest risk and should be treated most aggressively.
Dr. St. Ange has a
Thank
question.
you.
Yes, thank you. Thank you for the wonderful presentation. As a general internist and there's and primary care physician, when should we refer to you? Who are those ideal patients who should be referred to a lipid specialist?
I would be most happy to see people with familial hypercholesterolemia because they clearly have a much higher risk than average. But so there's no doubt there that those with severe elevations in either LDL cholesterol or severe elevations in triglycerides, I think we can certainly help such individuals. But people who are having medication-associated side effects, we can oftentimes be of great help. There are lots and lots of tricks that we employ to help people to get back onto LDL-lowering therapy. And also, we take very careful analysis of their eating habits, and in many cases, we can help them with getting their diets back into order. Interestingly, by the way, I recently encountered 2 patients in my clinic who had adopted a keto-based diet, and one of whom adopted a carnivore diet in which they were eating 3 to 4 eggs per day and beef and cheese throughout the week. And this patient presented with an LDL cholesterol of 370. And once we changed that patient's diet and had the patient on some relatively mild lipid-lowering therapy, the LDL cholesterol was 150. So it was really solely based upon adherence to a very, very high saturated fat, high cholesterol diet. So again, there are multiple things that we can do in terms of making a careful analysis of their diet and also a careful analysis of how to use drugs in a way that will enable them to tolerate these medications. And the vast majority of people, we can get them onto regimens that they'll be able to tolerate.
Thank you. It's actually 1 o'clock. Dr. Corrales and others who have questions in the chat, I'm going to leave the chat, the Zoom open, but those of you that have to leave, it's 1 o'clock. And please note in the chat the link for getting MOC and CME credit. And again, I thank both our speakers for an excellent grand rounds. Dr. Corrales, if you're still on, you can ask your question. I guess she signed off.
No, the question relates to gender differences. There's evidence that women are offered statins less frequently and also are more likely to quit the statins, perhaps because of the side effects. In your experience, have you noticed or do you have data on gender differences?
There's certainly a lot of discussion of gender differences, and even in that huge meta-analysis that was published in European Heart Journal, it was reported that women are more prone to statin-associated side effects. And in fact, if you think about the way the drugs are administered, 80 milligrams of atorvastatin, which was given in so many of the clinical trials, is a real load of the statin. And I think in general, we have to be sensitive to the fact that there may be differences in terms of statin tolerance, and we shouldn't deny women the opportunity to be treated with more aggressive statin therapy because the greatest benefits are seen in those who receive the highest doses of the drug. Having said that, however, I think it behooves us to be much more sensitive to complaints of statin-associated muscle symptoms in women and to moderate statin doses or use statin plus ezetimibe more frequently in women versus men.
Thank you.
Dr. Orringer, this is Dr. Mendez. I greatly appreciate your talk.
Thank you.
For those, I completely agree about the nocebo effect with the muscle symptoms, but there are some patients who it's pretty clear that it's coming from the statins with the classic symptoms. And I've heard of using statins once a week on those patients, and sometimes that relieves the symptoms and they're able, I'd just like to hear your thoughts on that.
Sure. So one of the approaches that I oftentimes, I mean, there's lots and lots of nuances here, but one of the things that I often do when a patient comes into me and has had difficulties on 4 different statins, and you know, the question is, do they need the statin? If it's primary prevention, the first thing I do is I check blood parameters, checking 25-hydroxyvitamin D, TSH, CK. Some of them turned out to have a myopathy to begin with. I mean, they have something going on in their muscles. They have you know, maybe there's an inflammatory myopathy going on that you're just kind of uncovering. So I get a good metabolic screen, take a good history, and find out, you know, if there actually a lot of people who complain of these symptoms actually are complaining of joint pains, not muscle pains. And in fact, it has nothing to do with their statin, because statins don't cause joint pain. And so but it's really taking a good history. Once you've done that, and it appears that they really need LDL lowering, there are a few tricks that I often do in the clinic, which it depends on the patient. But what I often do is I first start them on ezetimibe. Say, look, I'm not going to put you on another statin. I'm going to start you on ezetimibe. It's a non-statin, and the likelihood that you're going to have side effects from this is extremely low. It's generic, it's easily tolerated, it's beautifully tolerated. The incidence of side effects is extremely low. So a month later, they'll come back and their LDL cholesterol is maybe 15 or 20% lower in most cases, and that's a good start. If you had tried to put them on another statin, they probably wouldn't show up to the next time in clinic. They just, you know, they said, you didn't believe what I was telling you. You gave me another statin, and once again, the symptoms came back. So then I get them on ezetimibe. They're pretty happy about that because for the first time in a long time, they've had some success. Then the next question is, well, what do you do when you don't have enough LDL lowering? So what I do in those patients is I usually will tell them, I'm going to begin you on rosuvastatin 5 milligrams twice a week. Why rosuvastatin? Rosuvastatin has a long half-life. And as a result, taking it a couple of times a week can give you significant additional LDL lowering. So I will have them take it Monday and Thursday, and then I say, message me by UChart in 2 weeks to let me know if you're tolerating it. They message me and they say, well, I'm doing okay. I say, good. Move it to Monday, Wednesday, and Friday, and then a month from now, we're going to check your blood. And usually in those patients, you get a 40 or 45% reduction in LDL cholesterol. They're ecstatic. They can't believe that they have this reduction, and they actually are able to tolerate a statin. One other point that I think is very helpful in such patients is that when I tell them about rosuvastatin 5 milligrams, I do this. I say, I want you to understand, first of all, I'm giving you an extremely low dose of a statin. Now, they've been given 10 or 20 or 40 milligrams of everything else. 5 milligrams sounds real low, even though 5 milligrams of rosuvastatin is a moderate intensity statin. But the idea that it's 5 milligrams makes them really happy. The second thing I do is I say, this is the size of a 5 milligram rosuvastatin. And I show something that looks about the size of a grain of salt. So the idea that they see something that looks like a grain of salt and a 5 milligram dose gives them the idea that they actually can do this. And this thing just works like a charm. I mean, I do this in so many people. There are other options you can use, but I like that one in particular because it's a long-acting statin. It's taken a few times a week, and you can generally get enough statin into their blood that when you combine that with ezetimibe, you've really made some great progress. So again, those are things to do, but all of it has to be put into its proper context. You have to look at them carefully. You have to get a great history that takes a bunch of time. You have to take their dietary history and really look at it carefully. But if you do all that, and I mean, again, that's what I do in the lipid clinic, but you can oftentimes have surprisingly good results when you take that approach.
Thank you.
You're welcome. Are there any other questions? All right. Well, it's great to see everybody. And thanks for putting up with my presentation. Take care. Bye-bye.